For those of you who don't know me, I'm Asai Sham. I'm one of the ENT docs here, and we're privileged to have Dr. Itzhak Brook with us today to give the medical grand rounds. Dr. Kierbeck asked a few months ago about having somebody here who could talk to us from both a physician and patient perspective. And I've known Dr. Brook since residency. He's an infectious disease pediatric infectious disease specialist over at Georgetown, and he's also very frequent attender of our grand rounds and conferences. In fact, he actually gave the keynote speech or opening remarks for the American Academy of Otolaryngology Head and Neck Surgery National Meeting last year in Washington, D.C. And he's going to talk to us about his experience as a head and neck cancer patient. But just briefly about him, he was born in Israel. He did his training in Tel Aviv, and eventually he just told me that I didn't notice he did a fellowship in adult and pediatric infectious disease at the VA hospital in Los Angeles. So he's also has history and connection with us from that perspective. So we welcome Dr. Brook, and I'm sure I've heard a few of your talks, and I'm sure this is going to be great too. Thank you.
Good afternoon. It's a pleasure to be here. As you realize, I am a laryngectomy. I do not have vocal cords, so my voice is a little bit weak. But I hope that you can hear me well, and I hope that my voice will stay effective and strong through my presentation, because it's a challenge. As you can see, I speak with a small prosthesis which connects my trachea to my esophagus, and it allows me to speak without the vocal cords. Head and neck cancer is one of the most devastating illnesses people can experience, and it is that way because it affects some of the most vital functions of a person: to speak, to communicate, to eat, and to breathe. And those are very, very essential. Unlike many types of cancer that is not manifested on the person, head and neck cancer cannot be usually hidden, and people really wear it and show it. I thought that actually it's not such a bad idea that people can see it, because it's a sign that life can go on despite cancer. And this is why I'm proud that I can go on despite my small disability. What I also wanted to share with you, that I am a veteran of the United States Navy. I served in the Navy for 27 years, but I'm also a veteran of the Israeli Army, and this is really where I have my most significant war experience. I participated in the 6-day war as a medic. I had 2 more weeks for medical school, so that's what I did. And in the Yom Kippur War, 1973, I served as a battalion physician in the Armored Corps, and it was a very, very difficult and in many ways life impacted my life in many ways. I realized that there is a connection between war and cancer or any serious illness. sharing it with you because you take care of veterans. Many of them probably and unfortunately experience many dramatic experiences in war. And war and cancer and serious illness share these things. There is PTSD also after serious illnesses. There is what's common to both is the uncertainty of the future and the lack of control of the future. Because in modern warfare, you can be the most trained and bravest soldier, but if you're in the wrong place, in the wrong time, you won't have luck. But there is something good about the two, that if you survive them, you have a greater appreciation of life. And that's something that in many ways prepared me unknowingly, that about 35 years after the Yom Kippur War, I had to deal with being diagnosed with cancer. So what I wanted to talk to you about today is what it is to face cancer. How are you affected by radiation and surgery, and what patient can and should do to get better care, being a good advocate. And for me, my struggles to speak again, and what life is after being a laryngectomy. A few words about acute care of people like me who are in respiratory distress, and how to improve the care. First of all, we need to remember that every patient, beside having his cancer, has other medical issues. And a lot of time, including patients, focus on their illness, cancer, and forget other things. When I was diagnosed my cancer, the chief of ENT in Walter Reed told me, cancer is not what's going to kill you. You need to be making sure that nothing else is wrong with you, and you could keep good care of your medical and other issues. He said it to me because I sarcastically told him, when he told me the diagnosis, well, at least now I know what would kill me. Well, it's not only the serious illness, but it's also the things like diabetes, hypertension, and anything else that can cause morbidity and mortality. Once I learned I had cancer, I had immediately to deal with very difficult and unexpected issues. First of all, I faced for the second time in my life, after the Yom Kippur War, the need to deal with my possible mortality. I somehow put it aside and never believed that I'll have to deal with it until I really get very old. And I had to deal with it, with uncertainty, with anxiety, with fear. I suddenly became dependent on others, my doctors, my therapist, my family, and everything was affected. Relationships with friends, family, co-workers. I was still in active duty, and immediately I had to make decisions to tell everybody about it or not. I was afraid to share it because I was worried that I will be discriminated, and I was worried that people who would realize I have a possible terminal illness would stay away from me. And initially I didn't tell anybody except my boss at work and my close family. Obviously, once I became a laryngectomist, laryngectomy. I couldn't hide it anymore. One has to go through a grueling treatment with any cancer, including chemo, radiation, and of course surgery. Radiation by itself has tremendous side effects, as you can see here. Immediate one and long-term one. And it's difficult issues to deal with. It's something that it called, my radiologist told me, radiation therapy is a gift that keeps on giving. And it's true. Sometimes things last for, some of the side effects last for life. And here are some of the long-term effects of radiation, including hypothyroidism, fibrosis, even effect on the blood pressure. In my case, I developed a very unstable blood pressure. It was due to damage to the baroreceptors around the carotid artery. And obviously lymphedema is also a very difficult issue to deal with, needing treatment and consultations that last for a lifetime. One of the most important things patients need to know is that they need to be good advocates for themselves. I found it the hard way, because being speechless for a while after my surgery, I was completely dependent on the goodwill of the staff and my family, speaking and making sure that I get the right treatment. And having a good advocate for you reduces medical mistakes, increases the coordination. I realize that medical errors, unfortunately, are a very, very serious problem. I didn't see it before until I became a patient myself. And I'm not exaggerating if I would say that I notice about 2 to 4 mistakes a day, small and big, starting from using the wrong cuff to take my blood pressure, not responding to my calls, or using equipment that wasn't used correctly, giving me wrong doses of medications. I told the nurse, the doctors, that I have migraines, and the dose that I get is Imitrex 25 milligram orally. Well, he wrote that I am, and only because I noticed that the nurse was coming with 4 ampules of 6.25 milligram, I was able to stop her. Here is an example of an error that could be fatal. So there are a lot of mistakes that can take place. Patients need, if they want and can, to become experts with their doctors and challenge them, get a second opinion. In my case, I did ask for second and third opinion, but many people don't. And in many cases, it can lead to tragedy because very few things in medicine and surgery are etched in stone. There is always another way, and each patient may need their own way. And it's up to the patient to tell her story completely and accurately, and educate their doctors and caregivers about their spatial need. Otherwise, it won't get done right. Many patients are intimidated realize if I don't, I will be really getting bad treatment. And that is something people need to know. We are not infallible. We make mistakes. It's part of human nature. And the more advocacy, the better the patient care will be. Following surgery, it was very, very difficult and challenging. For me, couldn't speak. I couldn't talk and communicate. Patient definitely need to come to for follow-up. And unfortunately, many people don't, and that's really a tragedy. I was lucky because I came for follow-up every month. But after my initial diagnosis, I didn't have laryngectomy. I had a very minimal cancer that was treated just by radiation. But it recurred a year and a half later. And PET scan, CT were negative. But on direct endoscopical examination, it was discovered, showing you the limitation of those new methods. Adequate examination is very crucial. I came to my ENT doctors every month, and about 6 months before the cancer was re-diagnosed, I started to have pain on my right side. I told them about it each time. They looked at me, they examined me endoscopically and told me, we don't find anything. It's probably you have reflux, you have GERD, and gave me antacid medication. Only after 5 months, an astute resident asked me to do a Valsalva maneuver. While he examined me, Valsalva, blowing air with a closed mouth when he was looking, this opened up the piriform sinus, which is usually collapsed. And he saw right away an inch-big tumor that nobody else, including attending, looked and found before. A simple, basic exam is very, very important and should not be ignored. Also, one should not forget that there are many other issues the patient has, not only medical but psychological, that need to be addressed. I won't talk about my issues, but relating to speech, but there are many ways that people can choose how to speak. I remember that when I was in med school and saw laryngectomy about 50 years ago, I said to myself, how can those people live without speaking? And there was no way to speak then, except esophageal speech that very few people could master. But today, there are many, many ways that people with laryngectomy can speak, including the one I do today through the prosthesis, but there is an electrolarynx and other ways of doing it. So life and speaking should not stop after that. There are many, many issues, including their upper respiratory tract, dealing with issues relating to reflux, maintaining adequate nutrition, because swallowing is a lot of time a difficult issue because of the stenosis and fibrosis that happens in the respiratory tract. One of the challenging issues is respiratory care. In the case of an emergency, I did not realize that this is such an important issue until I had to get the emergency care because of hypertensive crisis. The nurses in the ER gave me oxygen to my nose, and I couldn't tell them that it was wrong because I was in really respiratory distress. It took 5 minutes until they understood by me signaling to them where and how to do it. So, educating how to do it is very important. Anesthetists, ER physicians, and anybody who is in acute care for patients, including emergency response teams, need to know how to do it. I have given talks in the community to EMTs about how to do it right and prepared a small video that is available on the internet at my blog, and you can take a card and find about how to do it. It's on YouTube and available also as a disc. That is still the responsibility of every hospital to make sure that the emergency room physicians know how to take care of laryngectomies and neck breathers. About 20 people a year, it's estimated, in the United States develop permanent brain damage because they don't get adequate care. In the case of respiratory distress, one of the most critical issues in all cases of serious illness, and especially in head and neck cancer, are the psychological issues. It's disfiguring, it's hard, and it creates many, many problems. You can see some of them, starting with depression, anxiety and fear of the future. Every time I had PET or CT, I was dreading the results. And then this is something that everybody does, fear every symptom. You need to understand it's natural for patients to respond sometimes inadequately to small symptoms. It took me a couple of years before I realized I don't have to rush to see my doctor for every little symptom that I have. I was lucky that my physicians were very understanding and never ridiculed me for doing it. But not everybody does. I was also lucky that I had physicians who I felt really cared for me. My ENT doctor used to hug me every time after I left his office, and his hug meant more to me than everything else that he did. And this is something to remember. It doesn't have to be a physical hug. Even a psychological hug, a care sensation that you can leave the patient with, will help them deal with many of those issues. Many patients end up serious illness especially, that affect the ability to speak, interferes with their earning capability. The fear of recurrence is definitely very scary, and I really don't have a good advice how to care about it, but I can tell you, in my experience over time, there is an acceptance of that uncertainty, and I am proud to say that after 5 years of my laryngectomy, I'm less stressed with any symptom. I had PET and MRI yesterday, my yearly annual one, and I was really a little bit anxious until my doctors came out and told me it's okay, and I was feeling okay. I can plan the rest of the summer. I won't have to go back to do other things, but this is something that will haunt me, but I learned to live with it with time. Dealing with depression is very debilitating. The suicide rate is the highest, the second highest, with people with head and neck cancer. I have seen patients through support groups and also in the hospital that don't commit suicide by actually doing it, but by simply withdrawing from therapy, giving up on life. And that's something that is very tragic and can be avoided. There are many ways that can prevent it. First of all, patients should seek help, should be encouraged to get help. There is social workers, there are medication psychologists that can help. Patient can and should be encouraged to return back to work. I know that what helped me the best was to go back to work. Unfortunately for me, I was at the retiring age and had to retire from the Navy, and really wish I could stay longer because I really loved every day there. But what I did is go back and volunteer. I still go to Walter Reed once a week. I go to Georgetown. I teach, and that for me made a big difference, because I feel I can make a difference. Many people can do it. What helps me is dealing with my kids, my grandkids. In my case, felt very depressed initially. And initially, paradoxically, being depressed was helpful because I said, well, I don't care anymore. Whatever happens, happens. But after 3 or 4 days, I say to myself, wait a minute, this is not right. What convinced me inside to change and become proactive was the thought that I was going to leave my children with a legacy that I gave up when things got hard. I knew that one day they were made to have to deal with hardship and maybe serious illness. I didn't want them to remember that their father gave up in the face of adversity. What also helped me and can help many others are support groups. There are support groups for every kind of cancer, including laryngectomy and head and neck. Every major center does. There is a support group in Georgetown that is open to everybody in Washington. For head and neck cancer, there is a laryngectomy society across the country, including Washington, D.C., and they helped me tremendously in the first couple of years. Meeting people like you who went through the same is very, very helpful. Unfortunately, one of the things that is forgotten a lot is a caregiver. It could be the spouse or a child or a friend. They often are ignored. They bear the brunt of the illness, and their own needs are a lot of time forgotten. They often get unappreciated, and it's important to realize that and give them the attention they need. That is crucial for their success. As physicians, I would ask you that you need to remember that when a patient comes to you with a serious illness, you need to be patient with them. You need to tell them again and again what's going on. Explain, repeat, and repeat. Patient may listen, but not hear. I know I didn't. My main concern initially was to beat the cancer. I didn't care what they told me. I felt, well, whatever they say, whatever they do, I'll deal with it. I don't have to think or remember. But it was important that I still heard and remembered some of it. Because when you wake up in the ICU with tubes, catheters, unable to speak, the words that you hear, the direction you get, are very, very important. One of the things that in my case was very upsetting was that, at least in the hospital, that I was hospitalized. It was in New York. The surgeons were superb, but they were overworked. They came, and I'm not exaggerating, at 6 in the morning, and usually left between 8 and 10 at night, going on morning rounds. I felt was something they wanted to get over with so they can go to the operating room. I felt that if I was lucky to get 1 or 2 minutes, it was great. I wanted to reiterate that spending time with a patient after surgery is very important. You need to be patient. You need to understand the patient is scared, overwhelmed, in many cases unable to speak. And your patience, answering questions, explaining, assuring them, is really very crucial and is a key to success. Life after cancer is difficult for everybody. It does have a lasting, lifelong effect. It really affects in one's identity in many ways. And it's important to develop a coping mechanism and a positive attitude to life. Well, not everybody is bad about being a laryngectomy. I don't snore anymore. If I don't want to smell something, I just do this, and I can go by somebody smoking a cigarette without smelling anything, because I breathe from here. I never had passion, my demons, is to make something good out of this unfortunate event by trying to make a difference. I try to make a difference by helping other laryngectomies. I wrote a book about it, which is available for free through the EDNEC, American Academy of Otolaryngology website as an ebook. I gave with a grant I got, free copies to all the training programs in the United States. And I recently published a guide for laryngectomy that is available free on my website, and you can get the address of it on the card that I left. So, and my voice is becoming weaker, so I needed to switch to another device. But what I think people should remember who have cancer, that by them going on, especially we at laryngectomy, that there are cancer on our throat, going on is a sign that life can still have a meaning and a purpose, even if one has a serious illness. And cancer should not be a time to give up or stop. So I wanted to thank you for your attention, and I would be very happy to entertain any questions that you will have. Thank you. Yes.
Hi, I'm Allison. I'm actually a nursing student. I'm wondering, you said that they didn't, in the emergency room, didn't know the proper way to administer oxygen to you. What is the proper way with that?
To give it to the stomach.
The mask?
Here.
Okay.
There is you can put the mask here. Or use a infant mask, which is smaller.
Is that where you breathe from?
Yes, that's how I breathe. And some people who have partial laryngectomy that breathe from both places. But I carry with me a card that tells that I'm a laryngectomy. Some people wear it on their neck, and that is important to deliver the oxygen correctly. It can save lives. Yes.
Hi. My question was, what was the reaction of your healthcare providers if you pointed out their mistakes? And if it was negative, how did you deal with that and make sure that you were taken care of?
Let me tell you that I write everything about it in my book. I wrote articles about it in the medical literature, about every aspect of what happened, including the mistakes. And I'll be happy to email you the article on the mistakes. Initially, I didn't respond because I couldn't. But my scariest mistake was a day after my laryngectomy in the ER, in the ICU in New York, in a New York hospital. And unlike Walter Reed in the Navy, where I had a nurse with me all the time, a nurse had 3 patients. So I was disconnected from my, I couldn't breathe. I had something stuck in my throat. I needed to be suctioned. And I was choking. And I was this way from the nursing station. Nobody came. So I disconnected the EKG. I thought they'll see a flat line, they'll come. Nobody did. I disconnected the PO2. Nobody did. And it seemed forever. It probably was like 5 minutes. My wife just happened to come in the morning, and she immediately called the nurses. And this can happen in the ICU, imagine. So I couldn't speak then, but I tried to be vocal. I tried to express myself by writing. One time, the nurses would every day clean it, my laryngectomy site. One morning, the resident made rounds, and the nurse didn't clean me. I asked the chief resident to clean it. Well, he didn't take gloves. He didn't do anything sterile. He just did it without the procedure that you're supposed to do. And I told him, stop doing it. I couldn't tell, I just wrote it. He wouldn't cooperate. And I was very upset, very helpless to oppose it, because I needed to be. And when I complained, nobody paid attention. I think that's an example of mistaken arrogance that shouldn't be tolerated. And this is why I think if my treatment would have been perfect, I would have never written a book. But it wasn't. And I think many people don't know it's wrong. But I knew. And this is why I think things should be done differently. And people should respond. I started to complain. I started to make a stand. What saved me, and there were mistakes too, in the military hospitals too. I'm not going to one of the two hospitals, I stayed in Walter Reed, the old one, and the Navy. And in one of them, there were many mistakes. And I tried to I was needed a laryngectomy. I became a laryngectomy in New York. I tried to complain, and they didn't take it very well. And my luck was my daughter, my oldest daughter, was my advocate. She made sure that everything was right. And that's very important to have a patient advocate with you. Mistakes are very common, they're human nature. And I think that staff should accept it and should learn from it. And the best way to avoid malpractice is to admit when it's right and cooperate and learn. And that's very essential.
Thank you. I'm really happy you actually shared the story about you in the ICU and needing to be suctioned and how important it was to get the nurse's attention, because kind of that stresses the importance of having laryngectomy patients when they are in the hospital close to the nursing station. So if they are in the regular floor or ICU, their location is very important. And so sometimes we want to make sure that they're somewhere that the nurses can see them, not just potentially hear an alarm, because the communication for a lot of our patients is not as good as yours, and we really are dependent on us to be their advocate, because sometimes they're voiceless. Aside from that, I'm always impressed, even though after a few years of doing this, of how important, and I saw that you had it in your treatments for depression or things to watch out for, is the hypothyroidism. That goes, because a lot of people don't think, that there was anything done with their thyroid, whether it's radiation or surgery, can have significant effect on the thyroid level, and that can make a big difference in how the patients feel, and also how they do with nutrition and also mood. And so that over the years, it impresses me each time when you do appropriate treatment for the hypothyroidism, how well they respond. So.
Yeah, I wanted to tell you that I decided to do something to prevent mistakes and errors and educate people better. And I created a website, a blog, and here is my blog site that has everything you need to know about caring for laryngectomy and head and neck cancer. And actually the book that I told you, the guidebook that I just wrote, is my blog in paper. And I have about 700 people who visit it every day. In it explained everything that I talked to you about. How to prevent mistakes, how to treat patients, and it's like a guidebook to patients and to physicians how to care for head and neck cancer. Yes?
You know, mistakes are relative, and it's in the eyes of the beholder. The fact that you've had so many mistakes and you're still alive, what does that mean? That these will not really make mistakes, right?
You're right. About every mistake, is this your guidance that I'm alive? That's not the guidance. What about suffering? What about mistakes that prolong illness? That I don't respectfully agree with you that being alive is enough. I can talk about mistakes that happened to me for a full session, including the need for laryngectomy, not doing the right procedure, not doing Valsalva. Every time when they did endoscopy, they would have found it. I would not have needed laryngectomy. I was lucky, but not everybody does. There are 20 patients with laryngectomy a year in the United States that die because when they come to resuscitate them, they don't know how to intubate them. Mistakes are not acceptable. Yes, they happen, but everything needs to be done to prevent them. Yes?
Can you tell us about feedbacks you received after sharing your personal experience?
I didn't hear it.
Can you tell us about feedbacks you received
Oh.
after sharing your personal experience?
I got very good feedback. I think that I hope that I was able to make a difference. I was fortunate to give the same talk to the American Academy of Otolaryngology. I had hundreds of people in the audience, so hopefully they learned a little bit. I hope that my experience will help other people. And my philosophy in life is to try to make something good of something bad. Really, this is my tragedy. But if I can make it into something good, then it was worth it. And I got a lot of positive feedback. I hope it will help other people. Yes.
Do you think being a physician had a negative or positive impact on your care?
The physicians.
So you're being a physician
Oh.
yourself.
It's a big question. I think overall, the physician treated me very nicely everywhere I went. I was treated in the military hospital in D.C., Walter Reed and Bethesda Naval, and in a hospital in New York. And the physicians treated me well, but when I got to New York, nobody really knew me. In Walter Reed and the Navy, I was their colleague, worked with them for years. Still didn't prevent many mistakes by nurses. the physicians in Walter Reed, were they, and I write about it in my book, that they took by mistake a scar tissue instead of the cancer, and which meant that I needed another operation a week later, and maybe prevented the complete removal of the cancer that mandated laryngectomy. But the attitude was positive, but not always competent enough. In New York, however, the residents and the attending were very knowledgeable, but very, very busy. I told you they work from 6 to 10 o'clock at night, and they love to be in the operating room, and they did a marvelous job. But there were a few attending who were not very humane, I would say, or considerate. And being a physician, really I don't think made a difference. Because I was speechless for so long, I decided to write about it. I think if I could have talked, I wouldn't have written it. But I felt so frustrated for being ignored, for being in many cases treated in a way that wasn't right, that I felt things need to get better. And that's why I wrote the book. I think the physicians there were well-meaning but very overworked, and that's why it reduced the real, true, good care that should be given after surgery. The operation was very well done.
If you don't mind, I'm going to just add a little something to that. As a physician and also having undergone cancer treatment myself, I found that there was periods of time where I potentially delayed decisions or made things more complicated than maybe they needed to have been. And eventually, once, after a few nudges here and there, and so there was a little bit of that experience. And if that's something that you experienced yourself in the beginning, especially when you first deal with the diagnosis and having to decide the right treatment plan, whereas a lot of times patients will let us kind of help them make that decision, or kind of even tell them what to decide, but maybe we may make things more complicated for ourselves. How do you feel about that?
When the cancer was diagnosed in 2006, I was still in active duty in the Navy, and I had no choice. I was treated by the ENT department in Bethesda. They removed the little tiny tumor, which was T1, and gave me radiation therapy. Everything was excellent, well done, minor procedure. Once I retired, I felt that the physicians were again very well-meaning and caring, but obviously I went to the people I knew for 27 years. I could go anywhere I wanted, but I chose to go to my friends in the military, and I only learned about it 2 days before my surgery. They have only had a case like me once before of a piriform sinus cancer, and I decided to let them do it despite the fact that I could have gotten better care in a place that does 2 or 3 cases a week. And that was maybe I should have done it that way, going to the experts. But I feel that because some cancers are rare, it should be done by people who have a lot of experience in them. And when they did the procedure to remove my cancer, they removed the scar tissue by mistake and didn't do a biopsy of what they removed. They took biopsy And a week later, the diagnosis came back. Sorry, you removed scar tissue. So it's a very basic fundamental mistake that the place that does it a lot probably wouldn't have done. So I think that there are mistakes, and people should recognize it. And things that are uncommon should be done in places where they do it a lot. And that was my terrible lesson that I learned. Because when they went back a week later, there was so much swelling and edema from the first wrong procedure. They couldn't remove the whole cancer. And eventually laryngectomy was the option. So I think mistakes are done. And because some illnesses are not so common, and the rate of throat cancer is getting low, there are less and less centers of excellence. And every area has one or two because of the rarity of that condition. And I think that we as physicians should realize it and say, wait a minute, I know what you have, but I'm not the best person for you. I asked my surgeon in Walter Reed then, 2 days before the surgery, how many procedures like this did you do? And he said, one. But he looked me in the eye and he said, if I would have felt that I cannot do it, I would tell you. And I believed him. And that was a mistake. The mistake was to say, the right thing to say is, look, I know how to do it, but I think that I'm not the best person for you. And we physicians want to help. But we should know that because medicine is getting more specialized, and we should realize that some things are done by more experienced people. And that's what I eventually ended up going to in New York, to a place that does what this surgery 2 or 3 times a week.
I think when a person with limited experience and limited resources tries to navigate the medical system in the United States with a serious illness, I mean, you're a sophisticated and educated person. You knew to go to Memorial Sloan Kettering or whichever hospital you went to in New York for specialized surgery. But many people would have neither the knowledge nor the ability to seek such care. And I think that they are really the ones who are the most vulnerable in many ways.
I fully agree with you. And that's why it's up to us, the physicians, to be honest and say to the patient, I am perhaps not the best person for you. As physicians, we want to help, but we also, there is I don't know how to call it, there is an inclination or temptation to get an interesting case. Wow, we got the laryngeal cancer. Residents should see it. I'll do it. We'll do it. They don't always want to give up patients, but for the patient's benefit, we should realize our limitations.
Thank you so much.
Thank you.
Look at your phone and feel like you reach it. Okay, did you need it? How lucky am I? Welcome to Chiefdom. Hey, very natural.
See how it goes.
Okay, I'm proud of you.
Do you need a service right on? Random projects, you just keep taking. You're really busy.
I wasn't. There is making daily.
Yeah.
There is making daily updates. Sheets that have like the accents from like and stuff. And then the people that are sick and she likes to use that. Oh, that's not the future. It's perfect. But now she keeps giving me more and more stuff. And now I'm doing like so much. I realize she can ask questions and plays with
That is odd.
It is, but I told her on it, she's like, it's just because you have a fresh pair of eyes.
That's true.
Thank you.
I didn't add anything, I just added her whatever, but I disagree with that.
Just wanted to thank you. I had kind of clinic, but thank you so much for your time. It's great.
Hi, I'm Joanne. You know, I see Joyce on Thursdays all the time. I'm here the other day with Queen of Ridge. Okay. Your story is very fascinating. To put that information out there.
She said something like she wants you to write about how you change it. Remember how you said about the to be a lot?
Hopefully you're, telling people what you're experiencing.
So they watch
make them more mindful. Because you're right. I mean, we as physicians, we know what to expect. We think about things, but I don't really go in the back seat. Obviously, patients out there who don't have all the or as you do, or I do, other people. Oh, to remind us to do the right thing, to pay attention.
No, I always. So what would you say is going to be where you said like 10 patients, for example, 10 patients where you did? These are the 10 patients that you're talking about. You know what I thought? I thought that is 10, you watch them doing the 10 cases. You have that one? But the part,
Yeah.
Thank you so much.
Thank you very much. I can see you out as well. Okay, very good. Thank you for coming. Appreciate it. Take care. See you around.
our attention, so
So
even
there's a
though,
specific test class designed.
it's called the so it's for HIV integrase resistance, and so they just, they have to get sample,
Yeah.
and
It's on their
usually,
website.
I believe so, and I think it's a slightly different sequencing, or excuse me, a different procedure than the Siemens, which we have been using. But, I mean, the sequence is a sequence, and if we get the right codon changes, our doctors won't prescribe integrase. But, probably, no, the Verbo-type, we actually can send them the sequence in a day or two. We get the results back. Siemens, yeah, no, we're not wedded to Siemens, it's just that we have history with them, we have used their Okay, questions about the easier way? No, absolutely. No, absolutely, and Rebecca's wonderful because she has been very receptive to our process. Well, not only because of that, but she's also a person that you can talk to. I don't want to make new work, I just want to make sure that our patients get that we give our clinicians a good turnaround, good enough turnaround time for their own decision making. And it sounds like what they want, at least for us to do, is a priority before we get authorization to pay given our experiences with purchasing.
Do you know where the people live?
Time delay, so that there is already a test at Quest.
Do you know where the people that work with this are?
What's that?
The people with audiovisual.
Audio-visual? I'll have to call them and see. I don't know offhand. I'm trying to get this whole room cleaned up. We've got another event going on. Who is it? Medical media. They said to move these phones out in the hallway, but they're all hooked over to some cord thing down here. You know medical media's number? Well, there's some man here that's trying to return the camera or whatever in here. I'm trying to get a hold of them, and I forgot Andrew White's number. 8136, I think. All right. Are they supposed to come pick it up or something?
No, they were supposed to give me a copy of it.
Hi, this is Tammy, Human Resources. I'm down in the conference room, GL 105U.
I talked to Brooke. I was a speaker. I gave a lecture. Yeah.
Some man was, wait a minute, I'm trying to understand this man who has a camera here in the room, and he was giving a lecture or something, and what do you need to do?
They promised to give me a copy of my presentation.
He was promised a copy of his presentation.
Okay, I believe someone is en route there now, but let me transfer you to Mr. White. Hold, please.
Okay.
Your call is important to us. Please
ceremony at 2 o'clock? Oh, your photographer will. Okay, also, there's another gentleman that was in here with medical media, I guess was given a presentation, and there's a camera down here. He said he was promised a copy of his presentation.
Yeah, I'm aware of that.
Okay, well, I guess he's standing here and... Do you know how, you're going to send it to him, he says?
I'm going to do it through, Dr. Kierbeck.
Gonna go through Dr. Kierbeck. Does Dr. Kierbeck have your address? I don't know. Do you all, does anybody have his address to send it to?
Dr. Kierbeck was requested, in the video, so I'm assuming that she has all the contact information. But it's not the medical service that, yes.
Oh, okay, this is medical media. He's gonna be getting the information from Dr. Kierbeck on medical service. He wants to know if he can give you his address.
Okay, I tell you what, if he can write it down, I'm coming down to pick up the camera.
Okay.
So, he can leave it for me, he can leave it
Okay, he left it on the podium. All right, thanks.
Hey,
What?
how you doing now?
I'm irritated.
I know we over here talking about the same thing. So you do the phone thing?
No, we gotta get the phone out of here.
Alright, I should come in here and move the phone.
Where's, EMS?
Yeah, that's a good one.
I'm so sick of them. Ian Clark.
We see? You want me to keep it in the box?
Yeah, just leave it outside, pick it up. Because you know what, when you take it up, you have nerves, you want to put that thing on, I have to tell someone what they do. Don't put your hand on their head.
Oh,
Hi,
okay.
this is Tammy. Is anybody coming to the 105U to set this room up? It's a real mess. Huh? Hello? He's arguing with somebody.
Huh?
He's arguing with somebody.
This ain't bad, that, she brings punch around, man.
Okay, we need this text off.
Okay.
Hello?
Make sure that's it before I leave. Punch your gloves.
Is somebody gonna be
spatula,
coming?
your forks. and
Okay, thank
plates.
you.
These were plates to sit in.
Oh, these are you take up.
Look at this fucking mess. Look at this.
What?
It was the face was right. Okay, there you go. Okay, she's ready to punch ramblings, okay?
All right,
All right, oh, come on, Sandy.
Did you have to run that food to someone? No, they're supposed to be coming to do it.
Did you find out, is it okay? Because I roll these phones on
Well, they're connected into the floor, Shirley.
To the who?
They're plugged into the floor.
Oh.
We gotta take.
Well, is somebody coming in?
No, nobody's coming down here to do jack shit.
Did you ask them?
I don't even
Timmy,
know
don't
that
take
I-
them things though, because you don't know how they work now. IRM has to do that. Because if you mess the phones up, then they're gonna have a, so call Mr. Brooks back and tell him
What's his number?
4943. I mean, there's nothing you can do about this. It's not on you. You done told what's going, so, I mean, you know.
All right, we're starting to set it up, so, we're gonna be set up the room set for
Right.
you, so I'm just checking, that's all. All right. I'll be your man, I'm your housekeeper.
Yeah, I'm the one that called to make arrangements.
Mr. Logan and Mr. Clark should be coming down in a minute.
Okay, very good.
I thought it was at 1 o'clock. I come down to class, I'm like, oh.
And that's when we, start the setup,
Setup,
and it
yeah.
starts at 2.
Oh,
I'm right here, right here, right here. Good. Okay, Tammy, you got it.
Good, thank you. Ms. Allen?
Oh, you want?
You know how
You want the aisle, right?
we want 4 chairs, each row we want to walk down, way
Oh,
here.
I'm gonna have to give you 3. I'm gonna have to give you 3 apiece.
I can have one. I need some of these tables taken out of here.
What about the blue chairs? You don't want to use
No,
the
I
blue
don't want
chairs?
these blue chairs, no. We need more chairs. We need some more chairs.
I gotta find some chairs. All right. Take those chairs up. Put them in that hallway around there.
No problem.
Take those chairs up. I'm gonna have to go find some chairs.
Mr. Brooks didn't answer the phone for us.
How many more chairs you gonna need? Give me an idea.
Well, we're probably gonna have like 50 people in here. More.
I don't think you could do 10. I don't think you could do 4, but I could do 3. With the eye.
Okay. We do this every.
I know we do 4, but
I mean, we need more chairs.
I'm gonna get some more chairs.
Let me put this table up here, put this.
Yeah, I could. That's terrible.
Right, and we can do
We
it.
gotta get a hold of them people. They didn't even tell us until this morning, or dear, that they're having somebody come from SunTrust Bank or something to do an award presentation, give them back $75,000, and they don't even tell